All right, well, welcome everyone. Just a huge welcome to all of you. Today we welcome our first speaker in our new Leaders in Public Health Dean Speaker Series. This is also, of course, my first opportunity to welcome all of you to a talk as the new dean here. So it's just an absolute delight and honor to see so many of you here on this beautiful August day. So just a little bit about the speaker series. The Leaders in Public Health Speaker Series is one of the first event series that I'll be launching here at YSPH as part of my deanship. I, like so many of you in the audience, believe deeply in the power of bringing together extraordinary public health thinkers, doers, and leaders into our school. I have seen over and over again over the course of my career the power that gets unleashed when you bring folks together, sometimes unlikely bedfellows, people who you wouldn't traditionally think of as public health leaders, but sometimes people who we very naturally and traditionally have thought of leaders in our field. As we pioneer together a new era in our school's independence, over the course of this year, we are going to welcome a series of folks to come and join us, to engage in discussions about scientific rigor, around diversity, equity, and inclusion, around ways in which the work that we do within the bounds of this school can affect the health of the world much beyond here, 60 College Street, but certainly beyond the walls of Yale, whether within New Haven, Connecticut, the nation, or the globe. So to kick off, before I come to welcoming our very first speaker, which is just an absolute delight to have her here, we wanted to do something a little bit fun and different for our very first Leaders in Public Health series. So I'm going to invite you all to take a look beneath your chair. There are a few of you who are going to have a special something underneath your chair. Did you get one, Melinda? So there's more than one. So we should have, I think it's 5 or 6. We've got a few of them, 5 of them across the room. We've got one. You can open it, sure. So you get a little, yeah, it's a little mug with a Leaders in Public Health Speaker Series logo, because we all need more caffeine or hydration. Love it. So welcome. Welcome to this beautiful community and to the change that we are going to create together. So with that, I'm going to say how unbelievably honored and fortunate I am to have Dr. Bhramar Mukherjee join us today. Bhramar is a pioneer in her own right, and I can think of no one better to be our inaugural speaker for this leadership series, because as you will soon learn, she is someone who embodies every aspect of public health leadership. Her career is noted for her methodological rigor, for her dedication to real problems, her unbelievable dedication to education and mentorship, and most of all, a commitment to doing work that matters and that creates change. So a little about Dr. Mukherjee, for those who don't know it. Dr. Mukherjee is currently the John D. Kalbfleisch Collegiate Professor and Chair of the Department of Biostatistics, which is the highest honor that the University of Michigan gives to its most storied professors. It's a university professorship that she chose to name after the man who was her greatest mentor in biostatistics at University of Michigan. She's also a professor of epidemiology and global public health at University of Michigan. She joined Michigan's faculty in 2006 and has been there ever since as a faculty member, as a chair, and again, now as a university professor. She's also the Associate Director for Quantitative Data Science at the University of Michigan's Rogel Cancer Center, so the equivalent of our Yale Cancer Center for those who are involved with YCC. She is, of course, a decorated researcher and thinker with a wide range of expertise, from cancer to reproductive health to cardiovascular disease and environmental epidemiology, but also across a variety of methodological disciplines, from Bayesian statistics through analysis of electronic health record data. One of the ways that she and I got to know each other was through her leading the creation of COVID-19, which was a data-driven predictive model to map the spread of COVID-19 in India This model was tremendously influential in terms of guiding the Indian government, as well as localities in terms of stopping the spread within India, but also got a lot of attention from mainstream media outlets across the world, ranging from BBC to NPR to the Times of India. Her scholarship has been cited nearly 16,000 times, which is pretty impressive, by a wide variety of folks, ranging from statisticians through applied public health experts. And among many, many other honors, which I could fill the full hour with, she was recently elected to the National Academy of Medicine in 2022. Bhramar is one of those people who inspires me every time I talk to her, with her depth of thought, her creativity, and her dedication to expanding data science and expanding public health knowledge beyond the confines in which we traditionally learn it. And so I'm just so absolutely delighted to have her here. Please join me in giving a warm welcome to Dr. Mukherjee, to Yale, and to our Leaders in Public Health speaker series.
No pressure. So to be a part of this inaugural moment for Dean Megan Ranney and for your school, a new era for Yale School of Public Health feels momentous in my own personal journey. I am going to talk about analysis of electronic health records data and real world data in general. And I am going to debunk some myths here about the usefulness of this data. But before I begin, I always believe in gratitude. I have to thank some people. And Hongyu Zhao is one of the people why I'm here. Hongyu, I always admired Hongyu from a distance, but never got to know the man. And Hongyu and Ning has become such personal friends. We ran into the Bridge of Sighs in Cambridge, of all places. And then everywhere I go these days, I just sit across Hongyu. This has been a strange phenomenon in my life, like in Cambridge, United Kingdom, in Davis, California. But he has been a wonderful, inspirational statistician. And I really want to thank for the department that he has created, the tradition for data science that he has created, but all the members of the Biostatistics department, as well as the School of Public Health, for really enriching that data science legacy here and the footprint at the Yale School of Public Health. And I cannot say enough about your new dean. She's a true trailblazer. It has been my honor to be inducted to the National Academy of Medicine at the same time as Megan, because I just think, oh my God, how did I get into the same league as her? Because being a data cruncher, a biostatistician, not really out there. But we are going to talk about that popular image of a biostatistician in a moment. But I'm really, really honored, and I'm really, really thrilled for the future of your community, because I know that she's a visionary leader in public health, and she's going to shake the world and really do wonderful new things to bring a marvelous community together. I also think this is a wonderful opportunity for all of you to come together on this beautiful August day. And it is truly an August audience, no pun intended. So a little bit about myself, and I think that Megan has mentioned a lot, but I really have to mention my hyphenated identity, which leads to the kind of work that I do. I grew up in Kolkata, India. And I was one of those nerdy kids who actually read math books inside novels. I grew up in a liberal arts family where math was uniformly disliked. So I do not know about the audience here, but my parents just totally disapprove of everything I do. But it also shows that I was in love with statistics. I have always been a statistics major since the age of 18. And so 32 years of living with statistics, that's what you are seeing here. I went for my BSc in Presidency University. Then I did my degree in applied statistics. Then I was not happy. I did my degree in mathematical statistics. And then I did my PhD, and so on and so forth. And finally moved to Michigan Biostatistics in 2006. So you see, for the first part of my career, I was really a theoretical statistician. I have no sense of data. I actually found myself in public health, and public health came to my rescue as an individual and as a scholar. And I hope that I can share some of that enthusiasm and part of that story with you this afternoon. I have had a fantastic time as an academic at the University of Michigan. I started as an assistant professor, and I take pride that I went through all the ranks that is possible at the University of Michigan, including the distinguished university professorship. So I'm very, very grateful to my community at University of Michigan. I also became the first non-male chair of Michigan Biostatistics, a department. Thank you. A department that was established in 1949. It took many years to appoint a non-male chair of the department. And I truly, truly believe that when this opportunity was presented to me, I seized the moment. I want to quote one of my favorite statisticians, Dr. Janet Norwood, who said that women have to take advantage of the opportunities presented to them. It often isn't quite as straight a career path it is for men. So I took that opportunity and I have never regretted it. We like ranking. So when I took over, when they go in our favor, and then when they don't, we find fundamental flaws with the methodology and talk to a statistician. So in 2018, when I became chair, this was the ranking of the top biostatistics department. Michigan has a legendary biostatistics department. I always say that it is one of the largest, kindest, and finest biostatistics departments in the world. But I just felt that I'm not competitive at all, but I just felt that we could do better. And so in 2018, this was a slide from my campaign pledge that I said, we can be like, we can go one step forward because we are very close, 4.3 and 4.2. It's within the standard error. So we could probably, go over. And in 2022, we did. And actually, we are still in that error bound, if you notice, but still we went up. But in 2023, in the evaluation of best health schools, we moved farther up. And that has been, I felt like I was on top of the world, and I did that. I actually took a trip to Mount Everest, like the world's highest. This is where behind me is Mount Everest. I went to the world's highest helipad. Before hypoxia set in, I managed to smile and take this photo. So, it has been a great time to be a statistician and to be at the helm of Michigan Biostatistics, a department I'm very proud of. I also want to tell you that I really, really believe in team data science. I don't think that statistics can do anything. Statisticians can do anything alone. We need a team, an army of different people with different skill sets. So any guesses for when the first statistics textbook was written? Statistics compared to mathematics and physics and all of this classical science discipline is actually a young subject. I just want to remind you of that. I have put up this reference, which is by one of the very famous statisticians, Alan Agresti. He wrote this paper on how textbooks have advanced different fields. If a course, for example, in categorical data analysis did not exist, writing a phenomenal textbook can put that back into the curriculum and really propagate the adoption of those methods. So this paper actually talks about different textbooks and how that has made the progress in our discipline possible. So any guesses for when was the first statistics textbook written? About what time? 1920s. Anything else? 1920s. Any other guesses? Close. I don't have a gift bag to give, and I was surprised that there's nothing under my chair. Okay, thank you, Melinda. So I appreciate that. I'm the speaker after all. So it's actually the first statistics textbook was written by an economist. And so I don't want to come back to the theme that how economists use statistical methods and get all the glory. But in 1901, an economist from the London School of Economics wrote the exclusively focused statistics textbooks, Elements of Statistics. So we are a very young discipline. And we have morphed into different kinds of tools and cultures within our own discipline. And if you talk about quantitative data sciences, there is medical informatics, there is bioinformatics, there is computational biology, there is computer science, there is mathematics, applied mathematics, you name it. Our profession has really gone big. And if I started my career now as a young assistant professor, I would really revolutionize the biostatistics curriculum. I find it very intimidating to go in front of a classroom of people who are so scientifically savvy, so quantitatively savvy, and talk about t-tests and talk about linear regression model. I would probably really change the curriculum into thinking about the statistical scientific context first, and think about the causal quantity that you're trying to estimate. And that almost always comes from scientists, comes from the domain-specific area. And then we'll think about when can we get to that estimate with observed data, and what is the math that is needed when we actually try to estimate that quantity with observed data. And then I'm not going to pledge allegiance to one doctrine and fight with each other. I want my students to know Bayesian frequentist machine learning because the world is coming together, computation is becoming feasible, and maybe you will have depth in one area, but you should have knowledge in and openness to other areas as well. So I really believe in inclusive data science, where we all are trying to solve a practical problem together. So I definitely feel that statisticians have a lot to contribute, but as a part of a magnificent team and where the science is driving our work. So the rest of the talk, and I run a summer program on big data. We have for the last 7 years, we have trained more than 300 students, and we try to actually follow this type of schedule or routine or sequence where we talk about the problem, and then linear regression, generalized linear regression, they come later. We do not indoctrinate people with a standard linear model because you have massive data sets, and to say that this model holds is probably much more of a travesty now than it was 20 years ago. So this new era of large N or large sample size, electronic health records are a particular example. We really need more flexible, assumption lean, non-parametric methods going beyond the traditional statistical models and embed them into a causal paradigm. If I was starting my career now, I was going to completely revolutionize the curriculum to get to this inclusive data science. I am going to come back to the topic of the talk today. My father is actually, as I said, I grew up in a liberal arts family, is an actor and director in India. During COVID, when I was doing all of this lecturing, I made him listen to one of my talks. And he was quiet. He's 83 years old. He still acts on stage, and said, like, Baba, what happened? You didn't give me any comments. And he just said, have you ever heard of the word pause? When we give lectures, why should we pause? We have so much knowledge, so much content, 83 slides to run through. Why should I pause? But since then, he's my father. So I tried to take his advice and try to divide my talks into 3 acts. And this talk, every act will have distinct themes. And after every act, you're going to have an interlude of music. You can leave if you don't like it. That's like your clue that, well, like, excuse me, you can leave. Because, if you buy tickets to a play, you always have the opportunity to leave. That should be the same for scientific talk. I should be keeping you entertained. Please don't do that. That would not make me feel good, but you have the option. So in Act 1, I want to talk about an interesting experience in my life, that how do you build data sets? We always hear that statisticians are playing in other people's backyard, but why can't we have our own garden and our own forest? And so how do you actually be a part of data making? That has been transformative in my career. Act 2, I want to talk about electronic health records data, or EHR. and what are some fundamental issues with trying to use this data. And finally, in Act 3, when I have talked about the data and the methods, I want to show you that why we should invest in data and methods when an emerging crisis happens, that's where you go first. There is no time to roll out population-based studies. We were in the minute, in the moment. Just because we had the team ready, we could dive into some of the COVID-19 problems that physicians were asking us about, frontline health workers. So I'm going to recollect some of those stories with you. So before I begin, I have to thank my team. My team is full of statisticians, epidemiologists, geneticists. We all work together to do something good. So Act 1, being part of data making, this started with me about 10 years ago. So University of Michigan, like all other campuses, invested in precision health initiative, not just precision medicine, precision health, where prevention was a big part of it. It was a cross-campus initiative where about $100 million were invested from the provost's office. The idea was to create a data ecosystem so investigators from different parts of the campus can use it as an accelerator and incubator. And that could be to validate some hypothesis, existing hypothesis, or agnostically query the database. I was in charge of cohort development, not really statistical analysis. It's who to recruit to this cohort. And that is sampling, and who is in your study is going to be a key theme in my talk. So the Michigan Genomics Initiative, we started, it's a longitudinal biorepository at the University of Michigan. We started in 2012, and I want to point out where patients were recruited. Patients were recruited as they were waiting for surgery. It was a very progressive consent form where we asked for electronic health information to be linked to biospecimens, but also have a potential to recall or recontact the patients if an emerging study or some return of results became necessary. We also asked for permission to connect their data set, the electronic health record and a biosample, to anything else which is linkable by social security number. We hear a lot about privacy and confidentiality, but this patient community gave us wealth of data to do this integrative data science possible. So many talks on electronic health records focused on how do you define a medical phenotype, because these data sets were not designed for population-based research. What you get is International Classification of Disease, or ICD codes, mostly designed for billing purposes. You also have lots of structured and unstructured data in the electronic health records, including your lab values, prescriptions, questionnaire, treatment, clinical notes. And it is a very comprehensive and complicated process where medical informaticians in the School of Medicine work on in order to use the structured and unstructured data to come up with a medical phenotype. One feature of electronic health record data, which is priceless, is the longitudinal information. In Michigan electronic health record data, the average stay time is about 7 years. If you want to recruit people into a cohort study and retain them for 7 years, the cost is going to be humongous. So many times after all of this algorithmic processing is done, we obtain what in the medical literature is called medical phenotype. Statisticians like to call it an outcome. People like to call it response as well, but I'm going to stick with medical phenotype. So the core data elements of MGI is really big data. It has more than 16 million medical encounters on about 100,000 people now, and genetics, after imputation, 20 million genetic variants. But as public health practitioners and scholars, we do not believe that an individual's electronic health records and genetics codified their existence. So we collected a lot of other social determinants of health, including behavior and lifestyle factors, environmental factors, family history. On a subset of the participants, we also have wearable data. So COVID did not really stop us because, as I said, I was in charge of cohort development. We rolled out an epidemiologic survey layered with the EHR. And it turns out that during COVID, people wanted to contribute to health research and they were playing with their phones anyway. So the response rate was something that I have never seen before. It also enabled us to figure out that instead of on-site perioperative recruitment, if we could expand our horizon to our catchment area. So we are able to mail out spit kits to collect genotype, to collect biosamples, and also expand it to this whole state of Michigan. So this helped us in, sometimes challenges have to be turned into opportunities. So before COVID, we already had worked on this data integrated data system, digital data ecosystem, where we had the core elements I mentioned to you, the EHR and the genetics data and the EpiQ survey. And then we linked to some internal data resources, but also from geocoded residential information, some neighborhood level factors, as well as prescription claims, national death data. And at that time, when COVID happened, we had this database ready. So when COVID came, we could actually layer COVID vaccination, COVID outcome, long COVID, COVID symptom survey, lots of different data portals into this data quilt. As I said, it would be great if US has a nationally integrated data ecosystem, but we don't. So what can we do in order to build this data quilt? So the good thing about, you might want to say that why do we care about Michigan Genomics Initiative? It's only 100,000 people. UK Biobank has more data and 500,000 people. But I do care. I do care because this is medicine in action on Michigan campus. I know this physician, I know this patient, and that means a lot to me to give back to the catchment area. And I'll show you that because we had an engaged participant community in early days of COVID, in May to June of 2020, we quickly rolled out a survey questionnaire about how Michigan residents are actually feeling about COVID exposure, COVID risk. And again, there have been larger studies on bigger population, but there is a touch of reality where the action is happening in our community. Later on, 2 years later, as a statistician, I think self-doubt is a principal characteristic of a statistician. I actually wondered, did we read that survey? Was electronic health record enough to give us the information? So we did a methodological paper. What is the added value of a survey when you have access to in-depth electronic health records already? And the conclusion was we do need the survey. So this is the future. Whether you like it or not, if you are a believer in population-based study design, which I personally am, I liked probability samples, electronic health records, which are non-probability samples, where I do not know why an observation is appearing in my data set, whether it's because I'm a hypochondriac or I have healthcare access, or my observation is not there because I do not have a day off to go and seek a physician help. I do not know. So it's a completely biased sample, but this is where the world is going. This is the Global Biobank Meta-Analysis Initiative, 24 biobanks coming together with 2.2 million, more than 2.2 million genotype samples. My genetics friends are so excited that an odds ratio of 1.02 is going to turn out to be significant. Sorry, but I do think that you can see that electronic health records are going to be used for population-based and scientific research. We cannot just resist it. So based on this experience of collecting data, and I must say that I learned how to recruit patients through this app called My Data Helps, where you can consent to electronic health records, not just at Michigan, but at other institutes where you are seeking care. We dared to propose a population-based study called My Care. This is very close to my heart. I was talking to Dr. Arwin about this in the morning, that this is a new study of studying cancer and environmental risk. And I have to say, this really, really arose of my community engagement through the Michigan Genomics Initiative. The participants in our community said, you are doing so much with genetics, but so much is happening in environment in Michigan. What are you doing about that? What are you doing about characterizing the long-term health effects of the Flint water crisis or the pollutions that is happening in Midland and so on. And so we proposed this study with two other strong leaders in epidemiology and environmental health. It's a new cohort of 100,000 patients. Michigan did not have a statewide cohort from 6 environmental injustice hotspots. So this is sort of really, you get your feet wet into data collection and then you just cannot resist it. We're going to collect data prospectively, repeated measures of omics data, measures of environmental exposure on a disease-free cohort 25 to 44. I'm sure by the time I retire, this cohort will not have enough disease points, but so many people are going to do research on this cohort because you want repeated measures of life course omics data. That's a major gap in all of the studies that we do. So how many people get to do these kinds of things? So have been really, really blessed to be a part of data making. So what is our Act 1 summary? I'm coming to the end of Act 1. The vision moving forward is that we have a rich data set with large N. This is something very important. We have been doing statistics on large P, small n, but we have large N and large P. This large sample size is really, really important. And this is a data resource. Lots of grants on Michigan Genomics initiatives have been written. Lots of grants about MyCares will be written. We are on that map of Global Biobank Meta-Analysis Initiative. It's a shared resource. It's not proprietary. It's not disease focused. People from pharmacy, nursing, medicine, even a historian could use it. And we really used this during COVID because we had an engaged participant community. This is something that as a biostatistician or a data scientist, we often forget what those rows and columns of a spreadsheet are. The rows are real people, and then columns are very important biomarkers that we all need to understand. So for my advice to statisticians who are starting their career or anybody, it's very, very important to have good studies recruited properly and inclusive data. So create your own studies, own your data. All right, so you had time to cleanse your palate. I gave this talk in UK and nobody knew this is the Jeopardy music, and it was such a lukewarm response. I was like, oh my God. So and so Act 2, Scene 1, now that I have set up the electronic health record in MGI as this dream study, I'm going to be the second reviewer sort of in Royal Statistical Society and tear it apart, right? So of course, these are good, enriching databases because patients are coming to a medical health system. They have natural encounters with the medicine, the clinics, and we have large sample size. We have lots of variables. I talked about the longitudinal data. The callback potential makes it very exciting for me, for Michigan Genomics Initiative. But it's an absolute disaster in terms of measurement, in terms of experimental design, in terms of who is in your sample. You have to really appeal to your classical notions of biostatistics and epidemiology in terms of generalizability, in terms of transportability, in terms of representativeness. Otherwise, it is going to be very difficult to make sense of this data. So electronic health records were not designed for population-based research. Every physician I talk to, they do not like it. They do not like putting in all of those codes at the same time they're looking at the patients. They do not like it. Hospital administrators obviously like it. They say health is a big business everywhere, and particularly in the United States. And recently I realized, actually, a physician told me that medical malpractice lawyers really like EHR because they go back and say, well, the temperature was this, the blood pressure was this, but you did not do so and so. So here is a lawsuit. And then obviously data scientists and informaticians like it because we can sort of show you our trick and say, well, now we are employed. So if you look at the common sources of bias in EHR data, and I interviewed a lot of researchers who work on electronic health record data, we agreed on 7 things which we really think are important statistical issues. There is a checklist for source of bias in electronic health record data from a medical informatics perspective, but that's more focused on data checking or reproducibility. But here I'm talking about measurement, I'm talking about transportability, I'm talking about inference. So missing data, confounding, lack of data harmonization, different biobanks. If you look at those 24 biobanks, one is an eye biobank, Michigan is a surgery biobank, NIH, all of us, is enriched in terms of historically excluded minorities. UK Biobank is a healthy population biobank. So you're putting all of them together. And so the heterogeneity of truly studied population, the true heterogeneity, but also artificial heterogeneity, which is coming from lack of proper data harmonization. Time, there is often restriction of how much, what can you know about time? How do you register and define time zero? And the 2 things that I'm going to talk about today is misclassification, that you don't get a disease because you don't have the complete capture of a person's health history, and also selection bias. And so in general, it may seem like it's a confluence of catastrophes, all of the above together, but for a given problem, that's what we are working on together in a team. What is most important? If I try to address all 7 of them, I will have no power left. But given a study, how can you make practitioners state what is most important to actually address? So there have been several strategies proposed from in the informatics community, in the statistical community, to bias reduction strategies in electronic health records. One of them, which is the most probably informative one, but very expensive, is to do chart review on a subsample or collect more data, which is known as double sampling, multi-wave sampling on a more random subsample of people. The second approach, which is more epidemiological, is you have tons and tons of data. Use it on a bunch of negative controls to calibrate your p-values because everybody is susceptible to the same selection bias. The third thing, which someone like me with a PhD in statistics in 2001, which is antediluvian, is going to do is to posit a model. Let us look at models and see if we can come up with sensitivity analysis and can make some sense of it. But one common thing, which is I have to mention in this era of large N, that the classical Neyman Pearson statistics told us to be focusing on power and efficiency, but we really need to focus, retool our thinking now and focus on bias because we have very large sample size. Power and efficiency is not so much of an issue. And so I want to illustrate this through a cartoon, and this is very well explained as a big data paradox, that what could go wrong when you have large N, in a paper by Zhao Li Meng in Annals of Applied Statistics and several papers since then. So electronic health record is a big non-probabilistic sample, as I explained. We do not really know why an observation is there. And so even if I have little bias, it does not really go away with sample size. But because I have 100,000 people, I'm estimating that odds ratio is so much accuracy that the variance is really, really tiny. So many people in the audience will say a bias of 0.01 is not that much, even if it does not go away with sample size. But if your variance is 0.000001, then you don't have an opportunity to overcome that modest bias. And your true parameter T is almost always outside your credible interval because you have this inflated sense of precision. This is very, very important to understand. If you want to be wrong precisely, very, very precisely wrong, you'll do nothing. You are going to analyze the data as it is. But if you do not want to be wrong with high probability, you need to recognize this paradox of very small precision not giving you an opportunity to overcome the modest bias that you have, which is not going away with sample size. So bias become very, very important, and you get over-optimistic p-values, unreasonably narrow confidence intervals. So when I first started giving this talk, my medical science school colleagues are like, Bhramar, What kind of depressing people are you statisticians? Forever, you complained about small sample size. We cannot do anything. We cannot tell you anything until you get more data. Now, I have given you big sample size and you're giving talks on how small is your big data. Well, how is that fair? But as you see, this is important. If you are trying to do inference, this is very important. If you're doing prediction, that's a different story. But if you're trying to do inference, this is very important. So I do think that before embarking on any analysis with electronic health records, which is not prediction, you have to think about this question. Stat 101, we walk into a classroom, we say, who is in my study? What is my sample? And then what is my target population? What is my population? From S to P, from sample to population, from statistic to parameter. We are not thinking about these things because we are that jazzed by that data quilt. Just think about us. Michigan is launching a health data science master's where we have tons and tons of machine learning, computing, algorithmic fairness. Why can't my friends in the computer science department introduce one credit course on sampling and study design? I truly, truly feel that the world will be a better place in terms of science if we did that. So I think sampling is incredibly important. And the cohorts you are running your algorithms are incredibly important. We are in the era of large language models, generative AI, but I do think that if you have poor measurement in a biased cohort, even the fanciest AI cannot rescue you because you're going to train your best algorithms on wrong data, really come up with incorrect conclusions, and then that is going to influence policy, further enhance disparity and equity, and come back into your data. In 2016, 81% of the world's genome were from European ancestry. In 2021, that number has gone up to 86%. It has not gone down. So 86% of genetic data comes from European ancestry. So obviously, if we just build polygenic risk scores on that population, we are not going to gain new knowledge, and it's further going to influence our risk stratification. I'm going to come back to that. But now let us come back to Michigan Genomics Initiative. This is a biased patient population. And when we looked at this population, 50% of people in Michigan Genomics Initiative have a cancer diagnosis, current or past. So obviously, it's not representative of the population. It's enriched in terms of diseases because it's actually collected from a perioperative sampling procedure. So it's a high concentrate. 75 to 80% of the people who were approached signed up for the study and agreed to give us so much data. If I compare Michigan Genomics Initiative in terms of prevalences of different diseases, so on the x-axis, you see different disease categories, and on the y-axis is sort of a ratio of Michigan Genomics Initiative with UK Biobank, which is one of the most commonly used biobanks. You see enrichment in terms of every disease category. UK Biobank is a healthy population-based biobank. Michigan Genomics Initiative is a is a hospital-based biobank, so you expect that. So you cannot really use it for estimating prevalences. So can you do anything with it? So when I first mentioned this to our former chair, Gonzalo Abas, he's a phenomenal geneticist. He has more than 250,000 citations, rest of our department put together probably. But he said, forget about it. I said, no, Gonzalo, I can bet 5%, maybe not 5%, 3% of my salary that this data is going to give you very biased estimate of everything that you try to do. In the beginning, we did a lot of genetic studies. And so we created, particularly for cancer, we created this incredible polygenic risk score website where we have 46 cancers and polygenic risk scores by different methods using MGI, UK Biobank. And I was very excited about this part. But in my heart, like, you know, there is this sort of a bird inside your head which says something must be wrong. What is going on here? So instead of being skeptical about data, we did do this work. And gradually, I realized that there is something going on here. And I'm going to illustrate this cartoon by showing you genetics is a great field where people have come together, they have built consortiums and great analysis and JWAS catalogs. So on the x-axis, I have plotted log odds ratio for a particular association, genetic association with squamous cell carcinoma and all the JWAS analysis and the top hits. So this is on the x-axis, lots and millions of dollars of population-based study. On y-axis, I have plotted the log odds ratios from a cheap, biasly collected, much criticized database, Michigan Genomics Initiative. And lo and behold, the concordance coefficient is about 0.9. I was like, I'm ready to resign as biostat chair because my intuitions are failing here. I can see p-values being concordant in some sense, but not point estimates. The point estimates are close, bias is not affecting. How can this be true? Our whole genetics team is going on full force. We are publishing, but there is something in my head which is saying that there's something wrong. We're not doing the right thing here. So with my postdoc, I tried to really set out to answer these two questions: that when is it okay? When is the population-based study and this bias sample going to give us similar answer? What is the math behind it? It's just not enough for me to know it works. I want to know what is under the hood. I aspire to be a mathematician at one point of time. This is my responsibility to society. And then the second thing is that this under capture of electronic health records. We are not capturing all the diseases. Sometimes we're missing something. Sometimes people are over-reporting something. So how do we take the phenotype misclassification and selection bias together? And so this is the meaty part of Act 2, Scene 2. I will have some equations here. And so I apologize because this is supposed to be like, an afternoon lecture, but I just have to. I'm trying to sort of just to show how a statistician formulates the problem. And so because the problem that I'm trying to solve is that what is happening here? So that's sort of misclassification of phenotype. And then who is seeing, who is in my study, who consented to Michigan Genomics Initiative? That's my selection bias question. So if I want to talk about selection bias or sampling, I have to answer the question that I asked you. Who is my target population? Is it the people who I approach for consent, the preoperative, perioperative population? Is it Michigan medicine? Is it the state of Michigan? Or is it the United States that I'm trying to extend these results to? And so how do I deal with this misclassification and this together? And I'd like to tell you that this matters. So there is a classical folklore that with measurement error, your odds ratios or effect sizes get attenuated towards the null. So it's okay, you just lose power. But this is not true when you have selection and misclassification together. So I want to show you a very well-known example of the odds ratio of cancer and biological sex. So here, we already know from SEER and many other databases that women are at lower odds of getting cancer, overall lifetime risk of cancer. But now I have introduced selection of my subcohort based on biological sex and also by other covariates, and I can get an answer which is completely wrong. It's not just attenuated towards the null and we can say that it's okay. It's going to give me a completely incorrect result of who it is at higher risk. So the two forces joined together, your classical intuitions about measurement error often fail if selection is dependent on what you are interested in. And that makes a lot of sense. Cancer and biological sex I'm interested in, but if I am subsampling with respect to cancer and biological sex, I'm going to get the wrong answer, and depends on how we are defining our inclusion-exclusion criteria into my study. So how does a statistician operate? So sometimes when you see these problems and you see all of these cartoons and a collaborator comes in and draws all of these pictures on the board, a statistician is really a translator. A statistician is putting your story into the grammar and language of statistics. I am thinking in this way, and I just want to talk about that philosophy without getting into too much math, that D is my true disease status. And what I'm seeing is not D, but D star, a contaminated version of it. I'm really interested in the relationship between D and Z, which is my predictor or risk factor of interest. It could be gene, it could be environment. And then I am not getting to see it on everybody. I am only seeing it on a selected subsample, which I'm going to denote by S equal to 1. And then I am going to say, how does D get morphed into D star? So I'm going to have a misclassification model, and I'm going to have a selection model, and I'll have a disease outcome model. Different covariates, W, X, and Y, are going to inform different components of my model where I'm going to get the data. And I'm trying to retrieve some true answer, a mathematical treatment of that question: when does selection matter and when it does not? So that's my goal. And so then you actually come up with models, right? So the first disease model, that the one you are after in the population level, let us, for example, assume that this is a logistic model and it looks like this. I have a selection model, that's my second ingredient, driven by the covariates W. And then I have data contamination model, which is sensitivity specificity model, which are again informed by covariates. This is where there is a twist in the story, because typically you'll have gold standard data. You don't have that in EHR unless you collect more data. You have to have EHR covariates X and Y influencing each of these models. And your success depends on how informative these covariates can you find. Do you find things which are informative? And if not, then let us be honest, we cannot really remove bias. We can probably do a little bit, reduce bias. So the question, mathematical question, then boils down to that this is what I'm after, D given Z, but I am seeing D star, which is a corrupted version, on a sample which is conditioning on S equal to 1. And the pictures that I showed you, sorry, I'm getting too excited. That's what happens when you put equations and a statistician. So the thing is that what all of this analysis that I showed you, we were doing this. And we are saying, well, God bless us that theta tilde is going to be same as theta, without thinking about when would this matter. And so finally, I'm very happy because we were able to establish a relationship between the analysis that we were doing and the analysis that we are claiming we are doing on the whole population through this beautiful equation that I'm not going to discuss. But I want to tell you that mathematics helps. Mathematics really helps to formulate a problem, to understand what you are after and what you're getting as a data contamination processes. So you must always see a statistician before you do a study, during you do a study, and when you analyze a study. But what I wanted to say is that you have this D star, the model that we are fitting, related to the truth by certain contamination factors. And we established a relationship that led us to develop methods to correct for this type of biases. And again, it depends on how much information you have in your EHR. So again, I said that once you establish this relationship, then the statistician recognizes, well, this is not quite the logistic model, but it looks like a transformed logistic model, another nonlinear function, and I can come up with methods. And lo and behold, after you do the methods, you are able to reduce the bias that I showed you in order to, when you apply the method to that particular cancer and gender odds ratio example. So then when it comes to selection bias, I think that we are blessed at University of Michigan. We have a great survey sampling unit who always do non-probabilistic and probabilistic sample analysis of how do you take a current data and make it more representative of a study population. So we worked with them in order to say that what kind of information do I know on my target population? Do I know individual level data on the target population, say US population or Michigan medicine population, or do I know some kind of summary statistics, maybe age and gender? Our methods dependent on that. What we did essentially were boiled down to a transformed logistic model plus some weighting. And the survey weighting came from the level of individual level data that you have on the external population or summary data. And we did tons and tons of simulation to show that in order to reduce bias, it's important to take care of both the problems, not just one. So that was sort of our takeaway. And then I was on this, really hunt that are GWAS always okay? That's why I started this project, to know that when does GWAS get affected? So finally, we found an example. This is age-related macular degeneration, not cancer, where we see that the MGI log odds ratio and the consortium log odds ratio, which you saw, like that concordance of 0.9 for that particular cancer, is not 0.9, 0.55. I felt validated. Well, it matters. But why is it happening? For a particular data example, it's not possible for me to say, is it misclassification? Is it selection bias? Is it different definition of the phenotype, different sample sizes? So that's why you need to formulate the problem into an architecture and also study the properties, because just doing lots and lots of data analysis does not give you intuition about what is true in general. That's why mathematics, that's why computation, that's why general frameworks become very important. And so does my method fix that 0.55? Does it make it like, well, these if I apply all of my methods with transform, logistically, and weighting, does it become like the concordance of 0.9? No. There is no free lunch in life. There is only reduced price lunches. So from 0.55, we get to 0.7 concordance with the gold standard estimates, not completely recovering the information. So every time I see a paper which says removing bias, I feel very sad, because you cannot never remove bias. You can only reduce bias. So a summary of Act 2, and I know that I'm running over time, and so I'm going to do the COVID part very, very quickly, that we propose several strategies to handle selection bias as well as misclassification together. In this case, I think 2 + 2 was bigger than 4, though the techniques existed. But JWAS was largely okay. This last point was very important for me, because in JWAS, your selection of participating, choice of participating in a study is not driven by the genetic marker most of the time. That's why that association breaks, and that's why you see with subtle odds ratios, we do not see enough bias. So it was very satisfying to do the math to just answer a question that arose from my studies. And so I'm going to skip this part, that we are really trying to develop methods so that people upload and are more rigorous about EHR analysis, that how robust their confidence intervals are, how robust their how robust the conclusions are. We developed this tool, this software called Samba, Selection and Misclassification Bias Adjustment. And so this is our package. Please let us know if you use it. And I am only responsible for naming it Samba. And these are some of our papers. The last one is actually a very good tutorial of how to use external population data in order to correct your estimates, taking several case studies into account. And with that, I think
needs to go. COVID part to stay for a couple extra minutes. We'll do the COVID part to stay an extra couple minutes. If you do need to go, totally understand. So yeah, we'll do questions at the end. We'll do some questions at the end. If that's
that's totally fine. So you know, I just want to say that I talked about the data, I talked about the methods, but then because we had all of these things ready, we could really jump into the EHR analysis for COVID. So I do think that the US is not the gold standard in terms of EHR data. There are many, many seminal papers using the population-based electronic health records from UK, for the National Health Services, Israel, Denmark. Sometimes it's a claims, medical claims like Clalit Health Services. Sometimes it's a population-based cohort. Large integrated data is very crucial. We have tons and tons of models. We really need better data. And we also saw that during COVID, there was an importance, a heightened influence of biostatistical and epidemiology in terms of real-world studies, and classical concepts of matching, confounding, selection bias, meta-inference. They all came together. So in terms of our sort of, if you can see the similarity that my Y or D changed to an outcome related to COVID. Z sometimes was race, sometimes socioeconomic status, sometimes pre-existing comorbidities, but we could use the same type of tools that is similar that we had done for the last 10 years on our data. And we also tried to understand selection bias in the first part of COVID. Who was getting tested? We are building models for selection by what are the characteristics which are driving people to get tested. I think this is very important to show that the color of COVID, that the outcomes are not similar across race, ethnic subgroups, even for a well-advanced medical care system like University of Michigan, we saw tremendous disparities, and we revisited those disparities 1 year later. I just want to show you one figure which actually allows us, because we had the EHR, we could do not just unadjusted comparison across the Black and white subgroups, but we also could adjust for many things in terms of neighborhood characteristics, socioeconomic demographics. And we saw that, so if you look at this graph is showing you a hospitalization, ICU admission, and mortality, and you can see that it is higher in Blacks compared to whites. This is quite well known. This is at the University of Michigan. But if you move 1 year later, thanks to vaccine, thanks to treatment, everything has improved, but not at the same rate. I think it's very important to notice that the progress has not been at the same rate, and we need to really understand temporal trends in disparities, not just the initial trends in disparities. We also did a lot of work with EHR data and novel design. So we did phenome-wide association studies in Michigan medicine. And in the beginning part of COVID, who was at high risk of getting admitted to ICU and hospital admissions? People were looking for clues because there were no time to actually do studies, population-based studies. So these were our tables or paper or figures that we are supplying to the frontline health workers, that this is what we are getting by a PWA scan of the whole pre-existing comorbidities portfolio and the landscape. And we did vaccine effectiveness studies. This paper is very close to my heart, where we take a very old epidemiologic study like case crossover study and understand long COVID or post-COVID, because there's so much spurious associations here. And we basically do a within person comparison and then also use flu diagnosis as a negative control. So this also shows the advantage of being conversant, being cognizant of designs in EHR studies. I think that's also very, very important. So Act 3 summary, having the right tools and the right team was very important to do this research. Working with electronic health records is both frustrating and fascinating. I think every physician, every analyst should be forced and required to give a declaration of what are the potential sources of bias in the EHR analysis, so that we are honest, and we should not make tall order claims based on imperfect data. I am a data dreamer, but I'm not the only one. You have joined us for this afternoon and even stayed over time. So you're a part of the data dreaming community. Thank you for your patience. Thank you for your indulgence. Thank you for...
So we will do question and answer. I want to, before we go into Q&A, first thank Dr. Mukherjee for this fascinating, quick tour through both your career, but also sources of bias. I think that we are all leaving with a little bit, some more tools in our toolbox, as well as some great questions to ask our colleagues. I also want to thank the 100-ish people that were on Zoom today. And I want to give a huge thank you to our staff. Both our administrative assistants, our communications team, the dean's office staff, our development staff. And if we could just do a quick round of applause for the folks that made this happen. And Dr. Mukherjee, we have a small and very insignificant thank you, which does not come with music. Now I'm inspired. Thank you. I am going to open it up for questions. I'm going to try to go back and forth between the in-person and the online. So those on Zoom, please feel free to type in your questions. We're monitoring those as well. And again, I do understand if you have to go, blame me, not Dr. Mukherjee, for going over. I was just too effusive in my intro. Questions? Hi. Yeah, if you could introduce yourself too.
Yeah, hi, I'm Amit Achra. I am the clinician, and as well as, interest in the observational research. And so one issue I think we face while trying to do the EHR is kind of falls into your selection bias of understanding the physician decisions to compare treatments where we can do the trials. And this whole idea about clinical trial simulation or emulation rather has come up. And one thing I struggle to understand, so for example, in your example where you did, you showed how you overcame a potential bias on your gender analysis, is that you knew the potential confounders and the randomization protected us, but we can't randomize everything. So my question is, with the large language models, trial emulations, large data, is there somehow we going to know the unknown, or are we going to adjust for those, or we'll still be limited by that?
So that is a great question. And I did not talk about the trial emulation part, which is obviously a very important area. Also, there have been several COVID trial emulation as well using EHR, and many of them have backfired as well, because you did not, even if you divide into certain temporal snapshots, factors are not the same. So that limitation of observational data, if anybody does not recognize, that will be a mistake. So I really think that for COVID, we did not really have choice, because we had to do whatever is possible, right? So start with whatever you can, do whatever you do, but you have to find something. So I would say that our conclusions were becoming less biased. Were they there? So I really recently started thinking, I signed a book contract on EHR data analysis, and another person is writing the trial emulation piece, because causal inference and EHR. But what I really realized, this theory of triangulation, right, of research, which is in terms of natural experiment, in terms of observational data and RCT, and putting that framework together of evidence synthesis, I do not think that without triangulation, I'll feel comfortable to have tall order claims. And so I think we should do our best effort, not let perfect be the enemy of the good, but be very, very cognizant and cautious of what are the limitations.
I love that. And it gets at kind of those reasons why all of the different methods that we use across public health matter so deeply, that we need all types of observational as well as experimental trials in order to approximate the truth a little more closely. We don't yet have any Zoom questions, so I will open it up again to the in-person audience. I'm going to go over to this side now. And I'll say, for those who have to get going, I will stop us by around 1:15, and then there will be some mingling afterwards.
So thank you very much for an excellent talk. Let me first, I'm Jeffrey Townsend, by the way, Biostatics Department. The first thing I wanted to ask was just on the topic of pauses. I wanted to ask, when you teach, as well as when you present academic research, you need to structure things in certain ways. And I really appreciated very much your early slide on presenting the scientific context as the motivation for going to the statistics that we do. And I really, it's sort of very close to what I do when I try to mentor students, et cetera. It does pose a problem, though, which I'm sure you've wrestled with. And I just wonder what your thoughts are on that, which is that it gets us away from the statistical, whatever. I'm from an evolutionary biology background, so I always think of like bird keys, where you say, oh, here's this kind of thing, here's this kind of thing, here's this kind of thing. Where do we go? Because there you really have to wrestle with the science first and then get to where you're going. And the science is, as you said, very heterogeneous and differential. So I just wonder how you think about, for the assistant professor who might actually take that advice on hand, what do you actually think one does to try to rigorously present that for a student and give them an idea on how to proceed through that process, since you can't just give an ABC, do X, Y, Z?
Yeah, that is a fantastic and very challenging question. And but I do think that in the in the 6-week summer program that we run, we basically start with a 1 week of thinking on potential outcome and counterfactuals in general. That's our first thing. Because we do not, so I think that if you first start with linear models and generalized linear models, and you go that direction, and then you bring in causal inference, and then you say that this is counterfactual, and you want to make different parts of this model flexible, that does not resonate very well. So basically, we actually talk about the theory of counterfactuals and potential outcome for the first week, and talking about random variables in general. And then we say that, well, causal inference people do prove these identifiability results and all the assumptions that you need so that a linear model or an interaction model or a mediation model gives you what the causal estimate is like. And we don't go through the detail that much. And then we say that, well, for some data sets, the linear model may work well, but with this big, massive data with 100,000 people, if I say that everything is linear, that's probably not fair. But we also have more data to fit more flexible models, right? We always knew that there is probably some departure from the model that we are assuming, but now we have more data to characterize them. So let us really open up our toolbox and think about more robust assumption lean methods, because we are not so persuaded by lack of sample size anymore. We really, really need to do the best. And then talk, so computer scientists come and give lecture, statisticians come and give lecture, and then classical biostatisticians come and give lecture. So we basically expose them to different ways of thinking about models. Models as a capture of a philosophical emulation of what is happening in nature. And different people come for a different culture. And then we actually teach them Bryman's paper about battle of two cultures, statistical modeling two cultures, and say all of these cultures are converging now. And you can see that people are conversant in many tools. Statisticians are using federated learning, and computer scientists are so much into causal inference. So we are really making this more inclusive and integrated, but science is at the heart. Mathematics is our path towards that, and we have to work in a team. So that's how we progress in the summer program. Yeah.
So I'm going to ask that our third question come from a student, and that will be our last question of the early afternoon. So I'm going to invite a student to raise their hand for our third and final question. No pressure, guys. I know you all are brilliant.
We have one.
We have one. Where is? Oh, in the back. I'm sorry, I didn't see you. Wonderful. It's good. I get my steps in. Here you go.
So I'm a PhD nurse, and I'm in the T32 program here in the School of Public Health and the NCSP fellow. But my question was going back to your model where you were looking at D and D starred,
Yes.
and looking at the differential impacts. How do you decide where your contaminants are? Do you do that a priori? How do you decide how many of those you examine?
That is a fantastic question, because as I said, each part of my information, like how do I get to sensitivity model, specificity model, or selection model, hinged on the assumption that I have covariates which are informing me. So there are certain covariates in EHR, for example, number of visits historically that you see per patient, which is informative of that, like, maybe my measurement error is less for this person because this person is utilizing healthcare. Past comorbidities. So this is also another covariate. Like if you have had a chronic disease, then you get to see the physician more often. Healthcare access variables, if you have those measured, those can also say that whether you are capturing D versus D star. Length of time in the EHR, this is also informative of D and D star. But for many of the cancer studies, we actually did a chart review of a subsample. That's why I'm saying that the covariates in the EHR can only get you to this far, but will not be able to give you a good model. Getting some data, some new data on a more random subsample, like the double sampling multi-wave chart review, is probably going to give you a more cogent model. And what we did in a recent project, because we did not have any idea, we throw in some of the predictors, but also the entire content of the EHR. And that's where I think some of the large language models and AI tools are going to help us to really look at structured and unstructured data together. The voice messages left by the patients, that all of these in terms of better phenotyping of taking the image into account, taking the lab into account, which is going on into our algorithm. But I am feeling that that's where if you go beyond NLP, if you actually get into the joint modeling, we'll get more better phenotyping data. Right now, I did one project where we threw in everything and saw that like, what is the variable importance, but in a statistical way, right? But that does not feel right to me, because I think that you cannot do everything from nothing. You have to put some effort into collecting better data too.
We all have a lifetime of work ahead of us. So, well, thank you, Dr. Mukherjee, for this absolutely terrific lecture. And thank you to all of you, our students, faculty, and staff for being here. I look forward to hearing the discussion as we all head out. There's some light refreshments and things outside. Enjoy, mingle, and thanks for coming today.
Thank you so much, everyone. And thank you, Megan.